All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. This is the 6th webinar presentation for our Transition to Value Learning Collaborative, focused on the transition to value. Today we have Shannon Calhoun to talk to us about, what are we talking about today? The big picture, results matter, and then we'll also talk a little bit about some action planning items, as well as the kind of next steps. So we'll post the action plan template in the download, in the files share download section of the podcast, as well as the website. So everyone can get that, and then we'll talk about next steps as far as wrap interviews in 3 months and 6 months. *2 will unmute your lines as you have questions as we go along, as usual, and please utilize the chat feature as we go. All right, Shannon, all yours.
Thank you, Caleb. Hello, everyone. This is Shannon Calhoun. It is week 6, actually, and it is the big picture results matter. I welcome all of you today and happy to see that some of you that were out last week are able to join. So we have spent 5 weeks covering a lot about what transformation is in regard to payment reform and delivery reform. And we covered history, drivers, tools and resources, and even how to successfully engage in the value-based payment movement. Today, what I would like to do is really talk about the effects of transformation on healthcare, both in the rural setting and national, as what's happening nationally is really affecting the rural landscape as well. So I did an environmental scan, and I looked at quite a bit of the material out there, and I felt that comprehensively the NRHA slides, these next 3, really demonstrate what we see in anything produced in the data world. There are some that are deeper dive than this, but really when you're looking at results, you see that what leads the conversation is hospital closures since 2010, and how many hospitals are actually vulnerable for closing today. You also will see on this slide that there's metrics that are focusing on what it delivers and what the financial impact of that delivery is, or the loss of that delivery. We also are really monitoring those and what's happening to not just those who have closed in the results, but what is happening now in the landscape of moving ones even closer to closure. This also came from Chartis and iVantage under the NRHA banner. This one is sort of the summary of that, and it moves up to 2018, which is probably the most recent information. And it narrows the scope a little bit exactly on the results or the impact of the Medicare cuts on rural communities, basically moving margins by to the negative by an increase of 4% in 1 year. This is a subset of, obviously, the original data set, but it still looks at the data in the same way, lost in revenue, lost in jobs, and lost against the GDP. It's interesting that this information is what leads. Counter to that, I did a bit of a dive on just what's happening out in the universe of healthcare and change. And the next 3 slides will have stuff that's highlighted with underlines, and those all should have links for you. They should be active links when you get to the slide deck, so that you can see more on the actual articles. But what I would like to say here is that I think I stated before in the webinar series that I heard Zima Verma speak at the National Rural Health Association conference in Georgia, and she spoke about HHSC really acknowledging the strife that rural hospitals and providers are struggling with. What she said there, and what's very important to note here, is that Medicare is acknowledging that and actually trying to produce some models that make it easy for them to participate in. The primary care first is that one that would be easier to participate in. It's a model much like comprehensive primary care plus, in that it's for small and independent practices, and it pays on sort of like a per member per month for every Medicare patient that's on your rolls. But there is financial risk involved in that. Now, it's not large, it's pretty secure, but it's still risk. And counter to that, even though they said they focused on rural providers, they're still driving new opportunities for people who are experienced in this. And what you see the difference of these two, primary care first and direct contracting, is that there's 100% shared savings. That's kind of a new thing unless you take on full risk, and maybe that's really what you would say is full risk, but 100% shared savings means that if you create savings, you get to keep it all. And that's very attractive if you have the capacity to manage your risk and you work in a system that has the capacity to have volume to do that. What's important to note in both of these is that CMS, HHSC, Medicare is not yielding to the fact that they're going to let any cohort not participate in value-based payments. They're going to try to make it easier for you to participate, but they aren't slowing down the train. It's continuously moving forward. So I thought that was really important. They're continuing to drive payment and delivery reform for newcomers as well as experienced folks. Also on this slide is how Medicare is expanding Medicare Advantage plans. A lot of what we've all focused on was really on the fee-for-service side, and there's a lot of conversation about fee-for-service going away. If you remember in one of the early webinars, I showed a bubble chart on an XY graph that showed that fee-for-service was the primary amount of delivery or payment form. Fee-for-service was the payment form for delivery for Part B claims. And today, I think 34% are in alternative payment models. They're getting close to the 50% mark. And that's important to note that they're still following that intention that they put out there in 2013, 2014. Covering any benefit, a Medicare Advantage plan can cover any benefit that is likely to improve or maintain health of beneficiaries in their chronic conditions. That is a type of delivery reform. It may not be full clinical delivery, but it's still delivery in some form that's meshing a little bit with the payer community. So we'll talk a little bit about an example of this in one of the other slides, but this is going to have a very important effect on rural providers and could be a negative, so we need to pay attention to that. Payers are now, on the commercial side, engaging in this delivery reform, and this is a little on the light side of delivery, not actually becoming clinicians, but you can see that Humana partners with Doctor on Demand to actually deliver virtual care services for urgent, preventative, and behavioral health services. What this does is Humana's saying as an insurer that they will pay for services delivered virtually. And this is a huge opportunity for almost anybody. You know, when we read the book, The World is Flat, technology was the first flattener, and flattening goes both ways. It means it's a good or a bad thing depending on how you look at it and who you are. So for instance, for rural providers who are willing to engage in this, they have the ability to perhaps offer urgent care and bill for it without having to do a lot of changes on their physical location. The same for behavioral health. The bad part about that is if they don't and people are asking for that, someone else can do that from a remote place and deliver that service in that rural community. So it cuts both ways. It's a huge opportunity, but it's an opportunity for everybody and not limited to just people who don't currently have the ability to really deliver urgent care or behavioral health services. The same goes for Cambia Health. They're partnering with the technology to use video, voice, and text for clinical decision making, so that's probably extending some of their care coordination and the ability to do follow-up visits. So both of those things are a type of delivery reform that payers are engaging and leading in that could be an opportunity for rural providers if they so chose. And finally, this is really looking at payment reform, really changing delivery reform, and this is much more robust in the change of delivery in that you're seeing full partnerships between major payers and provider groups. And this is just a sample. Actually, I follow Becker's Review, and they do a list of this almost every month on what's happening in this landscape of payers and providers. And you can see here, again, click on the links to read more in detail, but you can see that they are integrated primary care centers opening up, 5 in Texas. You can see that Medicare Advantage is creating an outpatient center, which is a real interesting move. I haven't seen that one before. And then there's that interesting play between Walgreens and CVS, as always, but they have connected with payers and technology to recreate that physical plant of the walls of a CVS or a Walgreens and making it more than a pharmacy with some added sidebar, not even health things. So they're expanding that with the bricks and mortar to become more than just a product, but now a platform. So this is a big example of changing the product into a platform. Again, I think that I've heard of a really astute hospital administrator in Colorado that started buying land next door to Walmart before they could put up a clinic, because they were starting to do that, to see that he could partner with them and put up a clinic, or at least just put up a clinic instead of Walmart doing that in advance. I mean, there's opportunities. We have to, watch the landscape from the rural side to see these types of opportunities. So, yes, I read the Managed Care Handbook in 1997. I don't know why, but it stuck with me, and this one in particular talks about virtual integration. And this is actually what we're seeing. It's each of the major segments of the healthcare system: physicians, providers, institutional providers, payers, and ancillary providers act in concert for a common cause, which is patients and patient-centric. But none of those are employees or subdivisions of another. This allows each party to manage its own affairs and meet its own financial goals without being managed by another segment of the industry. This was actually predicted as one of the successful models back in 1997, and we're actually seeing it here today. It's very interesting. I think that, again, there's opportunity, but it's an opportunity for everyone that could cause shift on almost every market of who is the actual leading provider in that community. So what I noticed when I did this environmental scan was that I did not see a lot of data that demonstrates the value of rural providers. I saw a lot of financial data about jobs, about what it means to a rural community, but as a rural provider, there was not en masse data about the quality or the value of what rural providers deliver. And I think there's a couple of really important reasons for that. One is that, of course, rural providers are small components of even big data. Rural is 20% of the country, so that definitely isn't what the focus would be on anybody working in big data. Second, there may not be a big enough cohort in any one given data set that someone's doing that doesn't have a lot of variation because of the uniqueness of every rural community and what it brings to the table. And then, so that's called the tyranny of small numbers. The other thing that I think is a bit of a problem for rural providers, particularly in the Medicare space, is that there is a sort of a time lapse of the reconciliation of cost reports that is pro or con but doesn't deliver consistency. If you haven't heard of there's a slide or a webinar presentation done in concert with Caravan Health and Stroudwater that really talked about this particular issue with cause and the cost report and the delay of reconciliation versus, I can't remember what words they used, but really the accuracy of after the post reconciliation, that what that true value was or what that true cost was. So that sort of skews data. And so those two things I think are big things that prevent us from demonstrating value. So moving to a point of what a standard is in regard to demonstrating our value, and again, going back to that critical important thing of hierarchical condition category coding, that one, demonstrates the disease state, the severity of our patient population, and number two, that you have the processes in place to manage that disease state. So here you can see value equals outcomes and patient experience divided by cost. Cost is the wiggly thing that causes problems for anybody doing big data. And then outcomes and patient experience, I think that we can win a lot on that with rural providers, but we aren't necessarily documenting it. This concerns me, and this is what drives me to feel like it's really important to have the conversations about engaging in value-based payments. You at least learn what you don't know. And so I think I used the slide, the big picture results matter, and this sort of breaks it down in a little different perspective. Sustainability of those rural hospitals that are closing is dependent on fair and equitable payment. Payment is dependent on results. That is the future. It's not a transaction in the contract negotiation. It is based on deliverable results. And results mean positive changes in available data. And the truth is there's available data that you don't even know is being used against you, and I'll give you an example of that in a minute, or providers anyway. So claims and some reports, some you participate in, some are gathered without necessarily you knowing. But the result is that providers are measured on results found in claims data and other publicly available data, and their revenue is directly impacted by these data. This is a new perspective, and I think that it is the foundation of transformation and payment reform and delivery reform. Delivery reform is the opportunity. Payment reform is what creates the shaky bridge of moving off of where you are to where you want to be. So hopefully this has given some sort of foundation to have conversations for all of you as Flex folks to talk to people in your communities. So working in Texas, and I saw Kwong's on the call, so Kwong, you actually will probably remember this, but as much as 5 years ago, Blue Cross Blue Shield of Texas created a program called the Blue Ribbon Program, or the Blue Ribbon Network. And what they decided to do was look at publicly available data, and that data included things like Leapfrog, Six Sigma, NCQA, and then things that they also collected in their claims data. And they measured this across 427 hospitals. When they measured, they ranked them as exceeds, meets, does not meet, not enough data, or decline. The percentage of does not meet was the largest percentage, like 49% did not have enough data. Not does not meet, but did not have enough data. And there was a pretty good percentage of rural providers in that number of 427. It wasn't the largest, but it certainly was a percentage of it. And once they determined who fell into the network, then because it was a network and it wasn't a new contract and it wasn't based on new fees, they actually offered the network to patients with the incentive of a better copay or deductible. So, for instance, they might have waived the deductible. They could still go to the same doctor, but if they went to the doctor that was in the Blue Ribbon Network, then they might not have to pay the deductible. And we all know that that could drive someone, especially perhaps a senior person or someone that did not have the resources to pay regular copays because of a chronic disease, would make a decision to go to the provider that did not have the copay because of being in the Blue Ribbon Network. This was circumventing negotiations with payers directly. This was exactly what the negative downside of taking publicly available data that number one, fell in the tyranny of small numbers. Rural providers didn't do a lot of those publicly available things, so mostly because it had a lot to do with market share, and rural providers generally have the majority of their market share because they don't have competition in their community. And then the other was based on inside data, and perhaps those urban centers were already in the mix of doing HCC coding or other disease state coding. So the results on this was rural providers or any provider that fell outside of this publicly available data were just bypassed without negotiation. I spoke with one of my providers that I've worked with for over 20 years, and he said, yeah, it's still in play, that actual network is still available. So it's a concern if we don't tell our story. And there's opportunities by engaging in new delivery reform, like what we talked about, just adopting first population health and learning in order to be able to manage that shaky bridge. So the last thing I would really influence you all is do you take risk or do you take risk when you're having a conversation about this? And the reality is not taking risk could be as big as taking risk. And there's a lot of conversation around that. There certainly could be a whole nother webinar on what the risk is of not taking it, but I've tried to show you a little bit about what that is today. If you don't take the risk of engaging at the lowest amount possible with all the opportunities of having data, more data than you would normally have about yourself if you're in an alternative payment model, and then having a way to actually see the results of that action based on that data, and then still get shared savings is an opportunity. It's the lowest risk you're going to see. So, you know, what is the risk of not participating is probably the first question. The second question is, where is your data that shows your value? Because your value will lead the participation. And it will help you actually be lower the risk of participating if you're actually demonstrating high value in your costs and outcomes. And then watch closely at what point the risk to participate will be less than the risk to not participate. Actually, that's kind of it on a question mark for you. I hope that I've helped. I hope that you guys have a better handle on what payment reform, delivery reform, and transformation is. I know that I left some time today for Caleb to take up some of the conversations about your action items, and I'll be here to help if I need to. Caleb, I'm handing it back to you.
Thank you, ma'am. So before I talk about kind of next steps, action plan items, scheduling wrap interviews, things like that. I want to make sure we have time for everyone to ask questions, clarify anything. It's definitely not your last opportunity to ask questions, get TA, and things of that nature. But what questions do we have? Kind of overall, does everyone feel they understand the world of the transition to value, alternative payment models, things like that better now than we did 6 weeks ago now? Geez.
Bill, thanks for that post. And I hate to hear that. It's certainly a concern.
Yeah, I read, and I think to comment on your discussion from today, Shannon, I read an article today. Let me pull up where it was from as I forwarded it out to my team. I read an article in healthleadersmedia.com, and it was really just talking about what hospitals are doing. The title of it was Transforming Care Delivery to Improve Health, to improve rural health care. I'll put a copy of it here in the link here. I thought it was, or a copy of the link there in the chat box. Transforming care delivery to improve rural health. And it was really interesting. It talked about profiled a couple different hospitals and what they're doing, but it talked about hospitals are starting to do what they can to help mitigate the reduction in inpatient visits and managing community health and population health. And I think your point, Shannon, of healthcare or payers are starting to do that on their end. Hospitals and communities are starting to do that on their end as well, and having results. And I think both ends of that spectrum are having results. So it's happening, structured or otherwise, mandated by CMS or otherwise. So I think it's great that we're starting to see and examine some of the different models. Please take a moment, guys, to complete these polling questions. We would like to make sure that whatever we do as outputs have good outcomes, and we want to make sure the Learning Collaborative is beneficial and helpful to you guys and your Flex program. In connection to that, I asked Andy to put it's a PDF. We will post the Word document that you can actually type in, but the action plan template has been uploaded to the file share in the bottom left, and that is the kind of item, or the real homework of this, and that is to identify one or two items that, based on your participation in the Learning Collaborative, you and your Flex program want to take part in. Facilitate an assessment or a survey with the critical access hospitals in your state to identify where they are in the transition to value and advanced payment models, or initiate discussions with half a dozen of them to at least see where they are and what resources are needed. Those are a couple different options, but we want to have one of these from each state with an identified objective, activity lead, timeline, who's going to be doing this. If you're working with a partner, if it's your Flex program and your hospital association, or if you do have an ACO that you're working with within your state, or whomever that partner is, And then the output measures, what are you going to do if you're going to facilitate a series of webinars? Output measures will be 3 webinars will be facilitated, and the outcome measures are that our hospitals will have a better understanding of the current landscape related to advanced payment model, and then any notes or thoughts that you have on that. We'd like to get these by the end of the week. So let me know what questions you have, and we will, like I said, we'll post this into the external SharePoint, the website for the Learning Collaborative. So you guys can have that, and we'll send out an email to that effect as well. And we also have plenty of time to have phone calls and help you guys walk through those. Shannon, this one, I would think global budget payment and budgeting would fall into advanced payment model category. Shannon, do you have any thoughts on that?
Yes, I agree. I think it would.
Yeah, I think global payment is, you know, getting everyone on board with a single identified payment for procedures or just kind of across the board. I think that makes sense. There's going to be a couple sessions on that at the reverse site visit in July. The Pennsylvania model is working on that. Maryland already has it. They don't have any critical access hospitals, but they do have a global payment or single payment methodology. And then I know Washington is working on that as well, or something akin to that.
Yeah, and I would actually, and I would say that as alternative payment model rather than advanced. In the CMS side, there's an advanced alternative payment model or an alternative payment model, not to confuse things, but yes, I would say that's an alternative payment model. Bundle payments, even sort of the direct care is kind of like it's not full global, but it's a lump sum up front type of payment. So it's not comprehensive global, but sort of like that. So yes.
What other questions do we have? Do we need to go back to the polling questions so everyone has an opportunity to complete those? Thank you, Andy. I wanted to make sure everyone saw the template that I was referring to. All right. I know some of you are not this quiet. Robert, Jody, Catherine, you guys are never this quiet. Star 2 will unmute your line.
Caleb, this is Jody. I said thanks. I don't have any questions, though. Thank you.
Aha! Thank you, Jody. All right, guys. Well, if we don't have anything else, then I guess you'll get a few extra minutes back in your day. I really do appreciate your guys' participation in the Learning Collaborative. I really want to thank Shannon Calhoun, our subject matter expert and partner in this. It's been really good, and every time this is the second one of these collaboratives I've facilitated, and I learn something every time and every presentation. So I really do appreciate it and appreciate your time. We will be sending out some email reminders with the action plan template as well as posting them to the external SharePoint.